what I'm going to talk about really is also on children, like the previous presentation I made. And this time we are going to focus on really some of the issues and the challenges we see or we face when looking after children, but also talk about adolescents. So this is going to be my outline. We'll look at issues of pediatric and adolescent HIV globally and regionally along the continuum of care, and we'll make specific reference to 1990 targets. We'll look at the specific challenges for children and adolescents, and we'll look at approaches for optimizing the outcomes, and we'll specifically talk about transition to adult care, because that is really our ultimate aim, to make sure that we hand over healthy young adults to our adult colleagues. So, as we all know, we have about 2.6 million children under the age of 15 years living with HIV. And in 2014, only 32% were on ART. And it's important to note that over 90% of these were in Sub-Saharan Africa. On the other hand, there have been significant gains made in reducing new HIV infections among children, so much that it is estimated that 1.3 million new infections were averted from 2000 to 2014. And when you look at some 20 countries that the UNAIDS has described as the part of the global plan, there was a 60% reduction from 2009 to 2015. And when you look at this closely, much of the reductions were well after 2009. Before 2009, from 2000 to 2009, there was a 24% decline, and from 2009 to 2015, there was a 60% decline. And much of that decline in transmission could be attributed to using more efficacious regimens. So what about for adolescent HIV? It's estimated that about 2 million adolescents are living with HIV, and 50% of these are actually in 5 African countries and India. And I'll show you a map later how that is distributed. The new infections, I showed earlier how the new infections have dropped very dramatically in the younger children. For the adolescents, they have not dropped as rapidly as that. And the AIDS-related deaths are still very high among the children, in fact, among the adolescents. In fact, AIDS is the leading cause of death in African adolescents, and the second leading cause of death globally. This is another looking at the figures. Just showing that of the 2 million adolescents, 82% are in Sub-Saharan Africa. For those that are newly infected, 61% are in Sub-Saharan Africa. And of the deaths, about 85% are in Sub-Saharan Africa. And when you look at the distribution of adolescents, when you look at this, those who are 100,000 and over, the dark blue, you will see that they are distributed in these few countries within Sub-Saharan Africa and India. For India, definitely it's because of the very large population that it has, but otherwise, per population, this is where the concentration of adolescents is, and Nigeria right there. So when you look at the new infection trends, whereas they have dropped sharply for all the other age groups, when you look at the adolescents, which is this maroon, you see that the decrease is not as sharp as, for example, in the 0 to 14-year age group. When you look at the deaths, it's even more dramatic. For the younger children, 0 to 4, there has been a sharp decline in the deaths over the years. For the adolescents, it's in fact increasing, which is a big problem. What about when we look at the continuum of care in terms of diagnosis, treatment, and retention in care and viral suppression? We all know about this continuum. And like Francois said earlier, probably we'll have 90 tattooed on ourselves by now. It's when we look at this for children, we realize that we have challenges along this continuum, and I'll look at this in a little more specifically. When we look at for HIV testing in infants and children, in 2013, it was observed that only 42% of HIV-exposed infants received an early diagnostic test by 2 months of age, and Similarly, there were low proportions of older children that received an early test. So there's a gap there, very far from the 90% that is expected. What are some of the challenges that have been observed along that? Our health facilities, particularly in the resource-limited settings, are under-resourced and poorly staffed. There is also, although many people have talked about provider-initiated testing and counseling, its implementation has been suboptimal. And also, we find in many places where there are several adults that have come for care, but they don't bring their children, and it's not very clear why they don't want to bring their children along. And then, when you look a little more specifically on coverage for ART, there is a big gap, especially in sub-Saharan Africa. This is a gap, a treatment gap, as shown by UNICEF. Overall, in Africa, it's about 72% as the gap, but there's a disparity, probably some slightly better coverage in Eastern and Southern Africa, but a bigger problem in North Africa and West and Central Africa. But overall, it's still not good enough. And what are the challenges to the treatment? Why is there such a big gap up to now? It's believed that for many people that the pediatric treatment is quite complex, and this is along many levels. First of all, previously, up until late last year and confirmed this year with the guidelines, with the WHO guidelines, there were several age-specific and CD4-specific indications for initiation. You know, there were this age cutoff and that cutoff, this CD4 level and that CD4 level. Sometimes very difficult for people to remember. And then as children grow, many of the drugs we give them according to weight. And some people have to remember what per kilogram dose you have to give, and that can be a problem. And also there's a need for different formulations and different regimens along the continuum of the age groups. And this still exists even with the revision of the guidelines. We have a different regimen for under 3 years. We have a different one for 3 to 10 years. And we have a different one for adolescents. So remembering all this sometimes is a problem. And the formulations as well. Sometimes you have to come up with a different formulation for the younger kids. And that can be quite problematic. Also, the capacity of health workers to treat children. Very many qualitative studies have shown that they are quite uncomfortable treating children, and that way they don't put them on treatment. And regarding viral suppression, there have been varied reports of suppression rates, ranging from as low as 40% to as high as 90%. And from the very many studies that have been written on this, there are several factors how that has varied. They are varied by population, by age, by drug regimen, by calendar year, by duration of treatment, and study design. Some in the clinical trials, we had certainly higher rates, and the observational study is quite lower. And sometimes the frequency of measurement from annual to 6 months or something like that. There have been some differences of suppression rates. And I'll look at some of them in specific. This is the ARROW trial in Uganda and Zimbabwe. From this was NNRTI first-line ART. We had suppression as good as 80%. And didn't matter whether the patients were monitored clinically or laboratory-driven monitoring. They all did well. Similarly, in the CHAPAS 3 trial, which was in Uganda and Zambia, the children who were recruited as naive quickly suppressed, and about 80% of them remained suppressed, and those whom we recruited as experienced remained suppressed all through. So suppression can occur in quite a large number of patients. But let's look at some routine program data. This is a study we did in 2009 at JCRC, the center where I work. And what happened in the younger children, these were children who are all below 5 years of age, and we looked at them retrospectively. They were all on NARTIs, and by then there are some who had started ART and had been exposed to single-dose nevirapine. And by then the the guidelines had not changed to say that all of them should be on PIs, so this was retrospective. And we find that those who had started on NARTIs, suppression rates were as low as 35%, at 24 weeks and 38% at 48 weeks. Slightly better for those who are started on PI-based regimens, 64 and 68, but certainly much lower than the 90% that we would want. And what about on second-line therapy? These are children who had switched to second-line therapy, and we observed them for 48 weeks. PI-based regimens, they did better, and at week 24, 80%, and week 48, 85%, which was quite better, but still slightly lower than the 90%. And what have been some of the challenges observed in maintaining viral suppression? We think that some of the drug options that we have for children are suboptimal, and we could do with better drugs. Some of the formulations are not child-friendly, and they could be better. Many of the drugs we have, some of them have a low resistance barrier, so they quickly develop resistance and failure. Then also requirement for special formulations for different age groups. Younger children may need syrups or granules or pellets. And then you need to adjust the doses as the children grow. Sometimes we've observed some children who pick their drugs and adhere to them very religiously, don't missing a dose, but somebody has forgotten to adjust their dose, because the child grew. Then emotional and psychosocial issues. A child, either mother goes away for a while and they get depressed and they don't swallow their medicine, or some, they move a home or go to a new place or go to school and they are bullied and the adherence is affected. The non-disclosure of HIV status and stigma. Stigma is something big for all communities, I would believe. What about for adolescents? Now, when we look at the continuum of care, what do we see for adolescents? Everything across the board is not good. Testing in sub-Saharan Africa has been reported to be as low as 11% for children 15 to 19 years. And then coverage has been observed to be low, and virologic outcomes are not good. And let's look at this specifically. Some of the barriers that have been observed for adolescents, a need for consent for testing. In some places, sometimes some people have guidelines or regulations or policies that require an adolescent to have an adult consent for their HIV testing. Some countries have lowered that requirement to 12 years, like Uganda, but there are many countries which require somebody to, even a 17-year-old, to be escorted by a parent to consent for an HIV test, which is a problem. And sometimes some of the parents believe that if you test the adolescent, it may be an indirect way of disclosing the status of the family. And then there is a community perception that adolescents are low risk, especially if they are not engaging in sexual activity. May say, why test these ones? They're not sexually active, forgetting that some of them could have acquired it perinatally. And then the language to discuss HIV infection. If they go for testing, you will have to discuss issues of sex and sexuality. And in Africa, we are not very comfortable talking sex with the children. So you don't want to discuss it and say something like that because it's considered a taboo. What are the correlates of poor adherence in the adolescents? Lack of guidance and support, the changing of caregivers. In fact, sometimes even poor relationship with their caregivers can be a problem. Schooling, they adhere very well sometimes when they are in day schools, and when they go to boarding school, they don't adhere anymore because they don't want to be seen with their medications. Sometimes they want to conform or to fit in with the people around them, and disrupted routines. Sometimes school is the biggest problem. They have a very heavy routine and they cannot be able to swallow their medications to fit within the school program. There is a limited knowledge about HIV status, whether it's in the school systems or with the adolescents themselves, and also psychosocial stress and mental health problems that come with that age group of adolescents. And adolescents also have clinical issues that really interfere with their with their outcomes, the HIV-related diseases, opportunistic infections and malignancies, organ damage, whether from the disease itself or from the ART, and the long-term complications, sometimes of the ART, like lipodystrophy, bone and renal toxicity, and chronic ill health and disability has been developed over there because for the sheer fact that they have had this infection for a very long time, from birth, from the time they were early infants or from birth up to the time they're about 15. This is a long time, and lots of things could go could go wrong along the way. So let's look at the strategies that we could employ to optimize the outcomes in both children and adolescents. One, for adolescents, we need to emphasize HIV testing. So much as we encourage it for PMTCT and EID. We lay a lot of emphasis on EID, but sometimes we don't lay that much emphasis on testing adolescents. We need to think about managing of long-term complications linked to ART, and that will definitely bring up better outcomes. For example, if an adolescent is taking a drug, a male that gets the gynecomastia, you need to deal with that, otherwise they will not swallow it. Then psychosocial and mental health interventions, being integrated together with clinical care. It's not enough just to give them ART. It's important that you get psychosocial support along the way. That will definitely bring better outcomes. So much adherence support is needed. This could be either individual approaches, as I will share later, or some group approaches like peer support groups are also very important. Others, we should have some prevention linked to sexual and reproductive health. Education and vocational training, quite important, because when they have a livelihood, especially when they're out of school, it helps them to remain in care, because they could get earn a living and also feel probably psychologically comfortable to continue their treatment. If there's something we can do about health system, that would be great. Increase the staff numbers, make sure test kits and drugs are available. It is one thing to make an effort and go to the health facility, but it's another to find that the test kits are not there or the drugs are out of stock. That's really a big problem. And simplifying guidelines, like probably the new WHO guidelines that we have, could go a long way, as I will demonstrate from the Ugandan data that we've seen recently. So what are some of the individual approaches? One, counseling, and then reminder systems. Some of these could help to improve adherence, like alarm clocks, the adherence calendars, and daily events. For example, if there is a radio program that somebody likes that is the same time every day, somebody could time their swallowing of their medications along that. Some of them it's prayer or a call to prayer. If they hear it, then they go on and take their medications. Use of pill boxes, for some people it has been helpful, and also disclosing of the HIV so that somebody manages their own ART. This is particularly useful for adolescents. What are some of the group approaches? Peer support groups are quite important. We've got good benefits from this. Group counseling, for example, like you would see somebody there educating a group of adolescents on using a pill box. Music, dance, and drama, quite useful, as you can see down there. And also sports, quite something that people get involved with and very useful. What about with the drugs? Then something that we can do to optimize adherence. Definitely if we get drug types and formulations that are efficacious, safe, but also having a higher resistance barrier, that would be very useful. And reducing the pill burden, let's say with fixed dose combination or single tablet regimens, that would be quite useful. Or using more user-friendly formulations like pellets and sprinkles or mini tabs rather than syrups, because these have been observed to be easier to handle, would also be a useful approach. Then short cycle therapy or short cycle interruptions, where you have 5 days on and 2 days off. With the recently released breather trial results, this was very encouraging that patients on an efavirenz-based regimen could be on therapy for 5 days and take 2 days off, and would maintain viral suppression over 48 weeks. That was quite a useful thing to look at. Now, I talked about simplifying guidelines. Let's see from the Ugandan data how this could translate. This was the Uganda government tried to introduce testing and treating all children before the WHO guidelines were changed. That is in 2013. And from the time that it was decided that it started, there was a sharp rise. In fact, there was a 74% increase in children initiated on ART in just 1 quarter. And as you can see, the biggest group was in those children between 5 and 14 years, And this is possibly because many of these were waiting in the clinics, naive, they were in follow-up, probably on Septrin, but just starting on them on treatment, the numbers quickly went up. And it's very, very important when you look closely, that starting of ART, we have levels of healthcare in Uganda ranging from referral hospitals and specialized clinics, but also health center 3s. Now, these health center 3s are run by nurses and clinical officers, people with diploma, they are diploma holders. Most of the treatment, most of the new cases were recorded at that level, from 25% previously to 33%. So most of the new patients that were initiated were at that level, meaning they were comfortable initiating children on treatment, even with their level of qualification. So let me end with transition. Now, transition to adult care should be a deliberate process, should be deliberate and planned, and it addresses the medical and psychosocial, vocational, and educational needs of adolescents and young adults with chronic conditions when moving from a pediatric service to an adult service. So it should be deliberate and planned. So there are some steps that have been described in transition. You need to assess their readiness and skills, then you prepare them for transition, then engage members of transition team, transfer them to care, and then follow up and evaluate. And along the process, when you realize that something has gone wrong, you go back and reassess, and then go on along the way. So there is a way you keep going back and forth and make sure that the process is successful. What are the barriers to successful transition? Sometimes the general knowledge about the whole issue of adolescents and moving from pediatric to adult care. There's some information that could be out there, but many people, especially in the adult clinics, sometimes are not comfortable with the adolescent issues. Sometimes they could be having an illness that is not yet, they are not healed from, or they could have a pregnancy. At that time, they may not transition, so they probably want to first cover that illness before they transition. Then the adult clinic waiting rooms, especially when they're overcrowded, are not friendly for the adolescents. They feel very uncomfortable in those places. And then other things, they may relocate to a new place. They may not have financial stability because by then, when they are in the adult clinics, everybody expects them to be independent. They may not be independent as yet. They may, sometimes they have schedules that don't allow them to attend as frequently as they may have attended before. So in summary, you have seen that the HIV outcomes along the continuum of care are generally unfavorable for children and adolescents, particularly in sub-Saharan Africa. But we have seen that they are much worse for adolescents than they are for the younger children. Several challenges exist, as we have seen, but we have seen that a multidisciplinary approach can optimize the outcomes. Not just clinical care, but marrying that with psychosocial support and community support could go a long way in improving the outcomes. Then transition to adult care should be deliberate and planned, and it shouldn't just happen by accident, but you should think about it and plan for it and evaluate it as you go along. So I'd like to thank the various individuals listed and the trial teams, as well as the Ministry of Health of Uganda. Thank you very much.